Good evening, everybody. We're just waiting for everybody just to join us. And once everyone's joined, we will start. A warm welcome to everybody that's registered with us and joining us today. I see we're on about 320, so that's very cool. If I can ask you all to make sure that your microphones are on mute, make sure your video is switched off. As much as we'd like to see your face, there's just too many of you. And I think for anybody, guys, thank you so much. Switch off your video. And if I can ask all you guys to send us in the chat box, send us a quick hi, tell us where you're from. It would be wonderful to see all the faces. We will be starting soon. We're just waiting for everybody to come in. I see some people. Haley, sitting there nice and relaxed on bed. I like that. So we've got there Romania, Indonesia, Illinois, Morocco, UK, Kenya, South Africa, London. Steve, if you hit the chat bar, you can see where everybody's coming in there. From Turkey, Malaysia, London, Port Elizabeth, New York, wonderful. Egypt, everywhere. Smorgasbord, United Nations, welcome. All right, we're just waiting a little bit. I think the one person that I did see there that I want to say a special mention to before I start with you, Stephen, is to say hello to Dennis Tarnow. It's a real honor and a privilege to have the doyen of implantology and somebody that so many of us look up to as one of the godfathers of implantology. So, Dennis, thank you for joining us. It's a real pleasure and an honor for us to have you. And I think as much as we wait, I'm going to just get cracking and just start. Even though we've got people waiting, I think we need to get cracking. So to start off this webinar, I want to say thank you very much, everybody, for coming. Welcome, everybody from around the world, wherever you are. It is a pleasure. It is an honor that you've joined us from so many countries. And I think, Stephen, that goes out because of who you are. You are such a world-renowned figure, and to have you at the Academy speaking to me in South Africa is one of the biggest honors for me, I have to tell you. And I'm just going to quickly say a few thank yous, and a huge thank you for making this happen has to go out to Southern Implants, Graham Blackbeard and Sue from Southern Implants. I want to say a huge thank you for the sponsorship for this evening, because without it, we certainly wouldn't have all the people on board. Without it, we wouldn't be able to have as many people, because this is exclusive to Zoom. We are not Zooming. We're not putting this live on Facebook. This is very, very exclusive. So without it, we would not have had to have the numbers. So Southern Implants, thank you very, very much. Stephen Chu, thank you very, very much. It is a pleasure to be here. And if I can just take a few minutes to introduce Stephen quickly. Stephen basically received his DMD degree from the University of Penn. Nice to see that you're at UPenn, Steve. I see UPenn has certainly got one of the strongest alumni, I think, in the world. And his master's degree from the University of Washington in Seattle in periodontal prosthodontics in 1986. Adjunct prof at the New York University College of Dentistry, again, one of the top universities in the world in implantology, in the departments of perio, implant dentistry, and prosto, and maintains a private practice in fixed prosthodontics and aesthetics. Dr. Chu has contributed over 60 publications, including 6 textbooks and the dental literature, and has given lectures naturally and internationally on the subject of aesthetics, restorative, and implant dentistry. And I think, Steve, that's the background, but I think the key factor is who you are as a person. And I think that's, for me, why it's such a pleasure and an honor to have you here with us today, because I met you through Dental XP, as I've met so many of my colleagues through Dental XP, which has been a wonderful experience. And I think we've grown, our friendship has grown over the years. And truth can say that if there's ever the gentleman in implantology, the gentleman in dentistry, it is you. And in everything that you have, but never mind a gentleman, you are also one of those people who is so well versed in the literature that sometimes you seem to know the literature better than the people who write it. which is,
No, no. Maybe Dennis, not me.
which is something really, really
Yes,
phenomenal to have. So,
yes.
uh, Steve, it's a pleasure and an honor to have you here. Thank you very much for joining us.
Thank you for having me, Howie. It's always a pleasure to see you. I think last time I saw you, we were having dinner together when you were in New York at that little Italian restaurant. So it's always nice to see you again and see that you're well and safe.
Thank you, thank you. I hope you guys are too. All right. So what we're going to do, Steve, I think without further ado, we can get cracking and we can start straight away. And I'm going to share my screen. And what we're going to do is we're going to start off just with a small introduction um, about what we are trying to show. If I can just find the presentation, there we go. All right. All right. So basically tonight's lecture really is about two topics. It's about dual zone therapy, which is a topic that Stephen's going to talk about, which him, Dennis Tarnow, and Maurice Salama published on, a great technique. And obviously the other technique we're going to talk about is socket shield. And we're not going to compare the two because I think Stephen and I have had many conversations about this, and it's horses for courses, and you choose what works for you and what doesn't work for you. But again, I just want to give a big shout out to Southern Implants for the sponsorship tonight. I want to always give a big shout out to my family at Dental XP, who are without a doubt the most important people who have influenced my education, and certainly the reason why I'm here with you, Steve. So to say thank you very much. I just want to also just give everybody a little bit of a thing. If you want to follow us, Steve, I don't know if you've seen Steve's Instagram page. Steve, you just joined us recently on Instagram, if I'm not mistaken, and yet
I
your
would
stuff
say,
is hot as hell. It was
well, I'm
fairly
trying
recent.
to, yeah, it's about 3 months or so ago. And Dennis just also recently joined as well. So
Awesome, awesome. Well, I think it's great to have two giants there because, I mean, the kind of cases and the quality of the prosto and the work and the porcelain and the work that you guys do is just out of the top drawer. So it's a real pleasure. For those of you who want to follow us at the Implant Academy on Instagram, we have two. I have my personal one and the Implant Academy, and obviously our webpage for anybody there. And then obviously follow Southern Implants as well. We urge you to. So the question comes down to what is aesthetics, and I think that's where we can start tonight. Is what is aesthetics? And from these great authors, I found this saying, which I think pretty much says it all: that patients today require natural-looking teeth and gingival architecture in the aesthetic zone. And I think that's the key. I don't know if you know these guys: Steve Chu, SJ, and Tarnow DP. Okay, very famous guys. And I think that's the crux, is that a lot of patients are looking for the tooth. They're looking for the tooth. They're looking for the gum that's going to enhance and embrace and kind of give the quality and give the emergence to the tooth. If we look at Thomas Hansa and Faud Curry, in one of their publications, they say the aesthetic resultant of implant treatment depends on the contour of the surrounding tissue. And I always talk in most of my lectures where we talk about Mauro Fradiani, where he says in his textbook, it doesn't matter how beautiful your restorative work is, it doesn't matter how brilliant the porcelain work is, if the soft tissue and the emergence profile is not right, if that 1 millimeter of transition zone is wrong, the case is a failure. And often you put in a case and you say to the patient with all excitement, what do you think? It looks amazing. And they look at the case and like, it's not bad. And you kind of, everything's just like, oh, after all that you've tried and all of you've done. So we're going to be talking about immediate implants. And from this classification from Christoph Hammerly, we're really going to talk about type 1. And that's really immediate implant placement, which is at the time of extraction socket. And I'm going to share with you just a couple of parameters that are very, very important. And the one publication, there's obviously a lot of stuff which is very negative, about immediate implant placement. But the one interesting article that I always am interested from Marco Esposito's group in 2010 in the European Journal of Implantology, He said that aesthetic outcomes might be better when placing implants after tooth extraction. And I know, Steve, you and I both agree on that quite clearly. It's less traumatic. It's less everything from a patient point of view. So it's really something that really it's a single procedure, atraumatic, minimally invasive, and I think that's why we've pushed the envelope so hard and tried to go for everything that we do. So one of the most important things when we look at what the rules are for immediate implants, I think this publication by Nick Elian from Dennis Tarnow's group that was published in 2017 is really a landmark publication that really tells us where we can actually do type 1 placement. In other words, where can we do type 1 implants, and really, where we can do immediate implants, and it's a type 1 bone. And we require that buccal bone integrity before we can think. Now, there's obviously techniques like the IDR and things like that that one can do, but essentially when you are trying to do immediate implant placement, one of the key factors is you need an intact buccal bone. If you don't have an intact buccal bone, if we look at all the other publications from Chen, from Valentini, from Joseph Kahn, from Schropp, we can see there's greater horizontal resorption, there's more early failures, there's a higher incidence of recession, and there are fewer sites with bone infill around the buccal of the implant. So type 1 bone is absolutely key. The second factor is that we know from Ferris's publication that when you have less than 1 millimeter of bone, you're going to tend to have far more bone loss. And here you can see in a case of mine, you can see in this kind of zone, you can actually see where we had collapse of the tissue over time. So despite whatever we did, we had collapse of the tissue over time. And this is something that happens. The thinner the bone, the more chance you've got, the more risk you've got. We also know from Vivian Chapuis's article, from Araújo and Danny Boozer, that when you have less than 1 millimeter, you can see what they show. You can see with the 1 millimeter, 8 weeks later, you're going to get up to 7.5 millimeters of resorption of the buccal. And this was a CBCT study that they showed. Whereas if you look at the slides below, you can actually see that when you had a 1 to 2 millimeter buccal thickness, that there was very little collapse. Now, I want you to understand that although this is important, it shows the collapse of the buccal bone, it doesn't show how the bone is going to heal over time, and that's the key factor. So one has to take into consideration this publication, as important as it is not the Bible. It doesn't mean because you have collapse of the buccal plate, you can't put an implant in because of the fact that the bones that it's going to collapse, because there are lots of different parameters which we will share with you that you can understand. If we look at how many cases we have buccal bone thickness, okay, from the publication that myself, Carla, and Jonathan did at Journal of Prosthetic in 2018, from Hung Ba, from Januario, from Vera, there are many different, as well as Vivian Chapuis and Danny Boozer's group. They showed that the facial bone thickness in the anterior maxilla has been shown to be less than 1 millimeter in 90% of cases. So that means that only 10% of cases have more than 1 millimeter, and they've shown that more than 50% have less than 0.5 millimeters of buccal bone. So that's an interesting thing, because if we then follow the RTI protocols, it means we can only do immediate implants in 10% of cases. But is that the truth? I think I personally would disagree, and Steve, I think you and I would probably agree on that, and we'll have a discussion around that a little bit later. And I think this comes down to, these are the key factors. These are the key factors that we have. And the key factors are jump gap. The key factors are your buccopalatal dimension of your socket, your implant diameter, and your 3D positioning. And I think these factors, okay, the buccopalatal dimension also plays a huge role in how big your jump gap is. Your buccopalatal dimension plays a huge role in your implant diameter and what size you can place. And then your 3D positioning, again, is absolutely key and is dependent, again, on your buccopalatal dimension. And I think this is something that hasn't been mentioned enough. And I think it's something that needs to be published more, because we need more of this information, because this is to me, more of the key factor and the key function of choosing where one can do a socket shield, or sorry, not a socket shield, an immediate placement versus a non-immediate placement. And then again, what type of technique do you go for, dual zone, or do you go for socket shield, etc. If we have a look at this type of scenario where we look at the different cases with jump gaps, and if we look at Ferris's article from Sands, Lang, and Lindy's group, they showed us that when you had less than 1 millimeter of jump gap, you tended to have more bone loss around the outside. In other words, there wasn't a big enough gap for bone to form around the outside. And if we look at, these are all my cases, and if we look at the cases and we look at this implant is probably far too wide. The implant is maybe a little bit too buccal. It should have been placed a little bit more lingual. And it's too close to the buccal wall. The buccopalatal dimensions were maybe not wide enough. And as a result, even though I might have soft tissue over the top of the implant because I have bone on either side. So single teeth, we are very lucky, because with single teeth, the bone on either side, if the bone on this side and the bone on that side will give us nice soft tissue regardless of what we have there. So we have to understand that. So it is very, very important that we understand. When we place the implant a little bit more palatal and in the right position, we find that we end up with a situation where we now have much more bone on the buccal side, and we start to have more bone. And the further palatal we can place it, and the more the jump gap we have, the more bone you're going to have around the implant. So now we have to start looking at the whole concept of how thick is the buccal wall, and does it mean that I cannot place immediate implants, in a whole different light, and rather look at these concepts and start saying, right, well, how much jump gap do I have? How much jump gap can I create? And from that point of view, if I can create a big enough jump gap, maybe it means that I can place more immediate implants, either with socket shield or with dual zone therapy. The second concept comes from Caneva, and there are many other guys that have also written these kind of publications. And one of the keys here is this publication, where he showed, when you look at the two cases, you can see here when you look over here at the bone on the bottom, I'm just going to draw it in a red line. When you look at the bone at the bottom, when they use the wider diameter versus when they used a narrow diameter in exactly the same ridge, you can see the difference is that there is exactly the same. There's much more bone on the buccal than there is on the one where there's a wider implant. And I think that's absolutely key with everything that we do in this result. And if I show you this one case, some of you might have seen it, some of you might not have. But this is a case that I did in 2000, where we placed a 5.5 millimeter implant. And when we finished the case, we thought it was immediate implants. We weren't doing immediate load, but we did custom abutments and things like that. And it was really a phenomenal result in everything that we did. And I was strutting like a peacock, thinking I was going to show this case at every conference that I could, and how wonderful it was. But the key came down to when I started following the case up over the long term, and you can see what happens in 2001 plus 6 months, and 2002. Now, as I've said many, many times, this is the kind of case where there's just two things you have to do. Number one, you've got to make sure your dental insurance is paid up. And number two, you've got to make sure that your passport is valid so that you can get out of the country, just in case. So this is the kind of disaster that really one has potential for if one doesn't follow the rules carefully and make sure that you understand the concepts of what we're talking about. 3D positioning, the last concept before we go to a poll and before I hand you over to Stephen, is really around correct 3D positioning. And again, 3D positioning from Cavani, from Ferris's publications, they show quite categorically how important it is to make sure that your implant is as far into the palate and slightly deeper in the palatal portion than we used to have in the beginning. And I think that is key in allowing to ensure, number one, that your jump gap is as big as possible, that you have as much space between the buccal plate and your implant. And again, by doing that, you will then create the space that allows bone to grow around the outside of the implant. And if you follow those guidelines, you will certainly have the type of thing. And if you look at this, again, one of my cases where if you look at the results here, if you look at where this is and you look at how much bone we've got here, if I had shifted this just 2 millimeters to the palatal side, the chances that I had bone over the buccal and the risk that I had of not getting that type of recession. So these are mistakes that I've made over time, obviously not knowing what these parameters are. So these parameters are really key, and I think they are absolutely critical. And I think that's where, Steve, the implant that we're going to talk tonight about, the inverter implant from Southern Implants, is one of those things which really makes a huge difference for this. So what I'm going to do now is I'm going to go to a poll, and Lara, I think I'm going to just carry on with this. We're going to go to a poll, and we're going to open the poll. If Lara, if you can open the poll, and we're going to ask you, what is your favorite technique for immediate implant placement? And Steve, can you see that coming up? Can you see the poll coming up?
Yes, I can.
Okay. So here you've got the four options. You've got number one, do you use dual zone therapy? Do you do dual zone therapy with connective tissue grafting? Do you do socket shield? Or is there another technique that you might employ? So what I'm going to do is I'm just going to stop sharing my screen. Steve, you can start sharing your screen, and
okay.
And we can go into that while the poll progresses. Okay, so we've given the poll.
Okay, great.
Yeah, we've got that there. That's perfect.
Wonderful.
Steve, thank you so much.
Wonderful.
Right, Steve,
Wonderful.
can you see the poll? Can you see the poll there?
Yeah.
All right.
Great.
So it's pretty interesting.
Wonderful. Yeah.
All right. So we're just going to give that a few more seconds just to go. We've got a few more people. Come, guys. Let's have some answers. Answer your questions quickly. Answer the polls. Which technique do you use? The more people we have, the more interesting it makes it, and the much better for the discussion. So let's have a look there, going up a little bit still. Soft tissue grafting is increasing, taking the lead. Coming up from the left side is dual zone therapy. Coming out in third is socket shield, and other. Trailing behind is low. All right, so I'm going to go up to 2 minutes, and then we're going to end the poll. And there we've got 2 minutes, so let's end the poll. Okay, let's share the results with everybody. All right, so the interesting thing is there we can see pretty much what everyone's doing there. 29% of people are doing dual zone therapy. 29% of people are doing socket shield. 31% of people are doing dual zone therapy and soft tissue graft. And then 20% are doing other, which is fascinating to see. What do you think of that result, Steve?
I think it's fascinating, but what was interesting is that if you polled people maybe 5 years ago, what percentage would be doing socket shield? It'd probably be a lot less. And I would assume that the other would be maybe delayed.
Absolutely. Yeah, I would imagine other would probably.
Yeah,
that's actually.
Maybe it's delayed.
I should have actually put that in. Yeah, I would assume delayed is good. But I think that's very, very interesting. That's a fascinating result. So I'm going to stop sharing, Steve. I'm going to hand it over to you, and let's go through a little bit about the whole concept of the inverter and where it came from, and how we got to it, and some cases on dual zone therapy. I look forward to hearing from you.
Great, no problem. Thank you for having me. Can you actually see my screen without the poll, or how do I eliminate the poll?
Yes, you can just switch off. You can just switch off the poll. Switch off the poll.
How do I?
Just
Switch
click
off
on,
the
just
pause.
click on
Stop
the
sharing.
top. Yeah,
Oh,
stop
I'll
sharing.
click
And
off the
then
top. Okay, got it. Perfect. Okay. And you could see me now?
we can see you perfectly.
Great. And how about yourself? Can you click yourself on the top?
You can see me. I took myself off so that you don't, so that I'm not in your, so I'm not
Oh,
in your
no
way.
problem. Oh, got it. Okay, fine. Well, Howie, thank you very much for having me. This is a great format that we could actually share and sort of, the conversations we have, either online or texting or, in person. It's really great to really sort of bring these things together. I think when you had posted this, we'd had a discussion that people thought maybe this would be a point counterpoint of dual zone therapy versus socket shield, but it's really about sort of sharing the concepts and how we've all sort of evolved, and also using some of the newer implant designs like you had mentioned from Southern Implants, a project that Dennis and I had worked on with also you evolving the design with Costa Nicolopoulos as well as Pio Osman in Sweden. So I want to give you guys a lot of the credit because I don't place implants, and consequently the design really had to revolve around you guys who actually placed them. Really the evolution is sort of interesting as far as where implants have gone. The original Branimark, and then Dennis's selected surface in '93, and then the tapered implant from Jack Hahn, and then, how things evolved. It's interesting that the coaxius has been around for almost 20 years, this, which we'll talk about, and you're familiar with it because it's from Southern Implants down in South Africa. Platform switching with Porter and Lazara, Peter Worley with the scallop, the V3 from Nitsan Bacaccio, and Graham Blackbeard and I working on the inverted design in 2016. So that's sort of the evolution. What's interesting to note is that really prior to 2000, we were doing most things as delayed. And then after 2000, we really, became much more involved in immediate, and a lot of the designs have really evolved more toward immediate therapy now. The dual zone therapeutic concept is interesting. It's something I learned from my partner, Dennis, where he was originally grafting around the gap. But what sort of developed was that graft material was by accident initially placed in the soft tissue zone. We would contain and protect the graft with our provisional restoration. And at this connection, we would see, very good ridge volume maintained, ridge shape maintained, as well as thickening of our peri-implant soft tissue. And so what initially was sort of by chance became more on purpose, and hence the dual zone, where we're intentionally placing small particle mineralized cancellous allograft in the soft tissue zone because by chance it was getting in there anyhow. And we just decided to do more. Dennis turned to me one time doing a surgery. He said, "Steve, let me just add a little bit more." And hence that's really the development of the dual zone concept that Dennis had. And we found that by grafting, grafting wasn't really critical for osseointegration, but it was important for aesthetics. And I think, Howard, you identified all those issues so elegantly in regards to why some of the problems were, and you shared some of the problems you had. And we also have some of those problems. It's not overwhelming, but it sort of gives you pause to sort of figure out and say, well, why am I having this? And you identify that pretty well. The reality is the following: it's really all about biology. And when you really look at teeth that can really have such a thin buccal plate around it, like you said, 90% of the time or less, it's less than a millimeter in thickness. The reason why such a thin buccal plate can survive around teeth is because it has a periodontal ligament and periosteum, but no marrow because the bone is so thin. One of the issues is that when we place implants, like you said, is that balance between gap distance and primary stability of the implant and implant diameter, which feeds into primary stability, is that if you really don't have enough gap distance for new buccal plate formation, initially, you may have a thin buccal plate that forms, but over time, it resorbs. And the reason why is because you probably don't have any marrow surrounding that implant, and you only have periosteum. And that may not be adequate in order to then maintain that thin buccal plate around the implant long term. And you elegantly showed that so well. And it's humbling to see when you see those things that happen. And the question is really, why is it happening? So the goal really, as you pointed out, is that maybe we need to have thicker bone around the implant so we have marrow or vital bone in combination with periosteum. And that will probably allow the aesthetics, not the integration, but the aesthetics to have better long-term sustainability. And I think that's the key. And you elegantly put that together. And the real key is that what Spray and Boozer showed is that it's not that you have bone around the implant, but it's really how much. And the goal that we try to now approach is about 2 millimeters around the implant, at least at the buccal aspect as well. And it's really all about biology. It's just that simple. It's just biology. Like you showed, here's an example, even with grafting, some of the issues. I mean, we did graft, but like you said, that balance between implant diameter for stability and gap distance is critical. And if you don't have enough gap distance around that, over time, after say a couple of years, you could have flattening and loss of the labia plate. And the second problem is also the papilla. If you're using a wide implant that tends to have a wide top, tapered implants defined by the platform diameter, is that then if it gets a little bit too close to the adjacent tooth, you do have the risk of losing the papilla because the reformation of the horizontal component of biologic width that Dennis had worked on, that could still influence the interproximal attachment and strip it. And hence you could also lose the papilla. So those are really two problems. It's buccal plate collapse as well as papilla loss with the meat extraction implant. So Inverter was really a concept that would potentially address those two aspects. And again, using implants, straight implants where you would try to line them up and do screw retained. This is an interesting paper by Cochrane that showed that there is a risk of apical perforation. Hence, using guides, I think, has a tremendous value in this regard. But the other factor is the following, is that if you were in a situation where then you would say, okay, well, let me, tilt that implant in this direction so that I can engage more of this apical palatal bone. Your paper also, how we showed that you did central laterals and canines, not just central incisors, the original work from Joe Kahn. And you showed that, about 80% of the time, there's more bone apical and palatal to the implant. The only issue is that even though you're engaging more of this apical palatal bone, you're bringing the wider part and the widest diameter part of the implant more toward the area where the buccal plate is the thinnest. And that sort of doesn't really make a lot of sense. Even with the coaxis, as we discussed in South Africa, Howie, is that, with the coaxis, you're intentionally drilling more to the incisal edge. So you're theoretically bringing the wider part of that implant closest to where the buccal plate is the thinnest. And I know you like using uniaxial straight implants because it gives you more of that coronal gap distance, especially when using the socket shield. So we had a very in-depth conversation about that. And that sort of never made sense to me, where you would bring the widest part of the implant where the buccal plate is the thinnest. That just doesn't make sense. So really, the inverted body shift concept was really a combination where we could engage more of that area at the apical part where you do have more bone to engage. But the coronal aspect, don't make it wider and make it a liability, shrink the top. It's a very simple concept. And the reality is you're not using the whole implant anyhow. So why would you just make it wider and potentially then compromise that gap distance? And that was really the whole basic concept behind it. So the idea is that if my partner Dennis wanted to use, say, a wider implant, we know that wider implants are great in soft bone. Diameter is a very good strategy for primary stability. But again, it comes at the expense of the coronal aspect. So by shrinking the top of the implant, not changing the bottom of the implant, but just shrinking the coronal portion and making it more narrow in diameter, again, keep leaving the apical part the same identity, then we could potentially maybe increase the thread pattern. But instead of having it wide and divergent at the top, we could make it more convergent. Again, the same would be for the coaxis, where it'd be wider at the top. And hence, even with the coaxis, by shrinking the top, even the coaxis version, then again, we're not having this wide portion that could then flirt with that coronal gap distance and get too close to the adjacent tooth and potentially compromise the papilla. So again, the inverted body shift concept, diameter, shape, as well as thread pattern and depth. I have to give you a lot of credit for the thread pattern and depth because I know you spoke to Graham about that. And that was one of the key elements, I think, in being able to change the design to get better primary stability. And the apical portion being around 60%. The original design was about 40%. Dennis and P.O. Osman and Costa really helped figure out what that percentage should be at the apical part. Like I said, I don't place implants, so they had to sort of figure that out. And I know you were responsible, Howie, as well for the thread pattern and thread depth and design of that, which was really just a brilliant design. And the coronal could be cylindrical in nature with not having very deep threads, the top portion being about 40%, and sort of that best of both worlds design. Don't sacrifice the diameter and the shape of the apical portion that gives you the primary stability, but shrink the coronal part that you're not using so that you could then get back to the gap distance that you need in a singular body design. That was really the whole concept. So again, these are my emojis, Howie. This is you. This is Costa, and P.O. and Dennis. So I hope I got everybody's emoji. And your version is a little bit more narrow for smaller teeth. And again, that thread design was really critical. So thank you for that, Howie, very much for that important input in the design. Having that labial bone chamber, again, instead of having a wide implant, shrinking the top just gives you the ability to just get more bone in there and thicken your buccal plate, again, without losing the effects of primary stability with a wider diameter implant at the apical part, where you have more bone that you can actually, use a wider implant in that apical area. This is just from James Chow. You could appreciate that sort of concept of the labial bone chamber, as well as interdental, where we could stay away from the adjacent tooth so that, again, we could have more of this tooth to implant distance. So even though the horizontal component of biologic width would then be a factor, if we stay away from the adjacent tooth, we don't have the risk of losing the interdental attachment or losing the papilla. And really the whole concept was trying to just get more vital bone at the coronal portion of the implant where you need it most, not just a reduced diameter platform that's only about 1 millimeter. This, depending upon the length of the implant, can be 4.5 up to about 6 millimeters in height of the coronal portion. So it's fairly significant. And what we sort of learned is the following, implant design cannot overcome biologic principles in wound healing. Any company that tells you that their implant design will overcome basic biological principles, in my mind, that's called marketing. That's a sales pitch. But the key element here is that what I think we should understand is that we can, sort of harness biology or work with biology to enhance aesthetic outcomes. So meaning that, Inverta is trying to get back to a skinny implant in the top to work with biology so that we could have more bone at the coronal portion. That, as you said, long-term means that we can have better and more sustainable aesthetics. And that's really the key. And that's, I think, an important concept to understand. I get this question all the time. I'm sure my partner Dennis gets this question all the time. Why can't you just use narrow implants? And so here's an example. These are compromised sockets, as seen over here, or limited socket dimension. So if you have a compromised socket, and these are pretty blown out, and Dennis and I, Guido and Valentina, are starting to really, sort of, I guess if you feel comfortable, they start to challenge themselves surgically. I'm sort of a little bit of a pain in the butt. I sort of whispered to them, I said, well, can't you try to put the implant in that socket? Dennis likes to do the one surgery, one time concept. And I agree, if everything is there, maybe we could manage this. Or a recent case that I had worked with Dennis, there's resorption here, but there's limited socket dimension or length where there's not that much apical bone where he could get the implant in because the floor of the nose or the antrum is right there. And these are the exact cases, but we were able to put the implants in. I mean, these were compromised sockets, and this is that case that there was limited dimension. So by enhancing the design, and again, Howie, I got to give you credit on the thread design because I know you spoke to Graham about the importance of that. That really allows us to get really good primary stability even in these type of situations. So back to the question, well, can't you use a narrow diameter implant? My answer is not in these clinical situations, not in these. And again, if everything is there, maybe the bone is not there, we find that we can really get those implants in. What about evidence? We are presently doing a publication. As you know, Howie, you have one of the arms looking at the inverted implant with socket shield. We have the other arm where we're doing it predominantly with dual zone therapy. It's a pretty broad group. We have about 6 groups in the US with Barry Levin, who's very critical with this. We have Nick Egbert in Utah. We have Mike Will. We have the Penn group with Harold Baumgarten and Bobby DiCastillo. We have a pretty broad group of guys that we're trying to collect. And this is just some of the preliminary data. We're talking about aesthetics. I don't want to talk about the primary stability. Maybe you could talk a little bit more about that. But we were able to get very good primary stability. Usually we're way above 50. We're more about 80 Newton centimeters on a lot of these cases. In soft bone, we are undersizing. So you could probably talk a little bit about that as well, some of the strategies. But in regards to aesthetics, if we look at ridge dimension at the free gingival margin, and it's a prospective study. So what we did is we measured the free gingival margin diameter of the ridge before extraction and then followed them. And we have some of the preliminary 1-year data now. And we found that we lost very little, if at all. So again, with using the dual zone therapy with the inverted implant, looking at ridge dimensional change prospectively, over time, we're finding that, you know, our results are looking pretty promising. And in regards to peri-implant soft tissue thickness measured 2 millimeters from the free gingival margin, this is just, you know, untreated how thick the soft tissue would be, measured 2 millimeters from the free gingival margin. We know that platform switching enhances it. We know that the coaxial implant also enhances it even more, but using the inverted implant with the coaxial design enhances it even more. So now we know that implant or macro implant design can enhance peri-implant soft tissue just by picking an implant design that potentially could enhance that. So this is some of the preliminary data. We're supposed to, I'll present more of this data down in South Africa when we have the annual meeting, and I know you'll present your data as well. And these are just some of the examples, whether it's single teeth, maintaining ridge dimension, you know, and maximizing peri-implant soft tissue, and even in situations of multiple implants in the aesthetic zone. So we're able to really, I think, get much more consistent outcomes. I think that's the name of the game. Not that it's 100%, but could we have something that gives us more consistent outcomes, I think. So before I hand it off back to you, you'd mentioned, show just one case. Here's an example of a patient I've known for a long time, fractured the left central incisor. She comes in, she thought she had chipped her tooth, but you can clearly see here that that whole tooth is floured. If you look at then the 1998 x-ray to 2019, you could see here a little bit more. She has a large incisive canal, but I don't think that's going to really interfere with the surgical procedure. And you could see here that root or the coronal portion of the tooth is broken below the osseous crest. The patient does have that root, as you had said, is sort of forward, and whereas all the bone, it's apical and palatal to the root of the tooth, and hence using sort of this coaxial inverted body shift or inverted coaxial design. We actually like using it because we can drill and engage all this apical palatal bone, but yet the coronal portion of the implant gives us a higher incidence of screw retain. The reason why I've known this individual for a very long period of time, it's because it's my older sister Genevieve, and I promise you I didn't knock her down the stairs when we were kids. So unfortunately at that time I wasn't able to treat her right away. So all I was able to do was bond her tooth back, and then I saw her about 3 weeks later. The only problem at 3 weeks is that now she's sort of borderline in this situation where she's starting to have some of an infection here, and she's starting to get a little bit of a crestal dehiscence defect because we sounded down to the osseous crest and it was about 4.5. We know that the average Crest from Coy says it's about 3 millimeters or so. So now we're sort of a borderline type 1, type 2 scenario, which, you know, concerned me a little bit. The tooth is extracted, flapless, that's the key. Again, from all the studies showing that, you know, where is the bone? Like I said before, your paper included the difference between your papers that the other studies looked at centrals, you looked at laterals and canines, so it's more comprehensive. And the bottom line is that about 80% of the time, that's where the bone is. So again, using straight implants, we find, you know, we use them. There are some indications for it. But like I said, usually in the anterior region, we're usually using the coaxis design. But we could talk about maybe the coaxis for socket shield is something we would probably not consider. And I agree with you that a couple cases that we've used inverted coaxis, we've actually used the straight version for the reasons that I'm sure you're explaining. And really just the inverta is just I think a better coaxis, because the original coaxis, like I said, had a very wide top. The coaxis is built into it so that even though it's an offset, they're all pre-mounted. So using this is pretty simple because the mount actually matches the offset of the implant no matter what the degree is. And again, for the anterior sites with dual zone, we sort of like using this design because it really works quite well. And again, it spins at 0 degrees. So again, the coaxis is a very nice concept. Dale House did that. It's almost 20 years old. Really, inverted coaxis is really the next generation coaxis. So it's just really designed for extraction sockets. The drilling protocol is really, you know, aiming more to the incisal edge. And that's where you sort of have to, you know, aim in that direction. Like I said, and my sister, her pre-existing root was really, there's like a little fenestration there, which is not uncommon. And the danger when using straight implants is that sometimes when the implant is placed, it can walk into that little fenestration and then perforate. So the coaxis is a very nice design because we can go behind that and sort of eliminate that risk of maybe perforating. So again, the coaxis is quite of a nice design. You go, has a marker on it to tell you the depth of where you are. So we try to place them. This is a 3 millimeter marking depth from the platform. We try to go no less than 3 millimeters and no more than 4. It also depends on the diameter that you're selecting. If you're selecting a 3.5 diameter head, or like even in the design you have, Howie's a 3.0, maybe you want to go a little bit deeper so that you have a little bit more running room for your prosthetics. And that's sort of a judgment call by the surgeon. But there are markers on it to sort of tell you where you are. And if you're using the coaxis, it has a marker on the buckle to tell you where the buckle is. And again, after the implant is placed, and has a dot on the buckle to also orient it for you as well. We can make the provisional restoration. We use these preformed shells, and then we can just trim them up. And then I always make the temporary out of occlusion, slightly in labial version, and relative to the adjacent tooth. And then now we're actually starting to do either a xenograft, or we're actually modifying the technique. I've had some conversations with Dennis, Guido, and Valentina about it, is that we're now doing or thinking about the dual zone, dual graft material concept, where we're still using the graft material also in the soft tissue, but where the bone is, we're thinking about maybe using something more robust, either xenograft like BioWash collagen, or a composite graft like Barry Levin uses a composite graft, a combination of xenograft and allograft, similar to what Joe Kahn has done with his grafting in the bone zone, using sort of 50-50 mix of xeno and allograft. And then we're using the allograft in the soft tissue zone in lieu of doing a connective tissue graft, because it's quicker, faster, and easier. And we found that an allograft, a mineralized cancellous allograft in the soft tissue zone, is not an irritant. So using something like Puros or something from BioHorizons, Mineros is the two products that we use. So this is sort of taking the dual zone to the next level of dual zone therapy, but dual graft. What is good for the bone, maybe something more robust, something that doesn't resorb quite as quick. But then in the soft tissue, we want something that will resorb within a reasonable time period, because we found that xenograft in the soft tissue zone can become an irritant. It's not always an irritant, about 10% of the time, but we found that that is very helpful. So we want something that will resorb in the soft tissue zone. And then the prosthetic socket seal concept from Paul Weigel and his wife, where we're containing and protecting the graft with our provisional. And that's how the patient leaves. This is 2 weeks and 5 months. You can see that we pretty much maintained the papilla. The swelling did go down, the infection. And you could see here a little bit more at the 5-month mark. Now I want to go back to the original. Remember what I said, the original preoperative condition was sort of borderline on a type 1 and a type 2 socket. And in this situation, you could see up close, again, the xenograft in the bone zone or a composite graft in the bone zone. And you could actually see the allograft in the soft tissue zone. So you want something more robust where the buccal plate is to maintain that. And you want something that will resorb in the soft tissue zone. And just the dual zone is something where, you know, it's in replacement of a connective tissue graft. We don't say that you shouldn't put a connective tissue graft. If you are using the dual zone, you may not need to do that. But if you're only grafting where the buccal plate is, then I would recommend that you at least do a connective tissue graft if you're not using the dual zone technique, or do Barry Levin's technique of doing dual zone and dermal apron technique. So these are just all the different aspects of that. And you can see here, remember that this implant was placed roughly to where 3 millimeters from the free gingival margin. And you can see here that we were actually able to hopefully reconstruct that part of the buccal plate that started to have a little bit of a dehiscence defect. And again, you could see we were able to maintain the papilla at this connection. We did have a little bit, maybe if I'm ultra critical, to have a little bit of contour change. So maybe this is not a 14, maybe a 13 out of 14 for the pink aesthetic score, but I think that it's certainly acceptable. Screw retained with the coaxis design. So we like using the coaxis because it gives us, you know, pretty good incidence of screw retained restorations. The final crown is actually not great in shade, so we have to remake it when we get back to our new sense of normal. But I think when my sister smiles, I think this is a pretty, you know, reasonable outcome and something that we consider on a fairly consistent basis. Which leads me to really the socket shield or the PET from Howie. Howie, you've done probably the most amount of work on this subject with Maurice and Jonathan. So I think you guys deserve a tremendous amount of credit. The modification of your technique, the surgical technique, we do advocate, we do use that. So I think that's been extremely helpful, and your honesty and transparency in your outcomes is only trying to help our profession. So really that's a tremendous benefit. So we do follow your protocol with that. And if you could send us your PET kit, I think Dennis would greatly appreciate it. The indications that we really feel for socket shield at PAT, the number one indication by far that we all agree with, and Dennis would say that's too bad we can't get him on a conference call, but he would say that an ankylosed tooth, you know, the options are, does he destroy the ridge and try to reconstruct it? If it's an ankylosed tooth, everybody knows how difficult it is to try to peel off a tooth that's resorbing and turning into bone. So an ankylosed tooth we find is a perfect indication because that tooth is resorbing anyhow, it's being turned into bone. So we believe that this is the number one indication for socket shield, especially if you're sort of an initial learner. I think there's very little risk because, you know, that shield that's resorbing and turning into bone won't dislodge. So you don't have to fiddle or face some of those issues. The second indication that I learned from Dennis and also James Chow from Hong Kong is that if you have a really, really thin, ultra thin labial plate, and this patient has an ultra thin labial plate, or even, you know, bordering on a type 2 socket where you have a dental-alveolar dehiscence defect, then maybe the socket shield is a great indication in those situations. And the last one maybe is this, which I don't know, and hopefully you can comment, is that if you can't get 2 millimeters of new buccal plate reformation around the coronal portion of the implant, and it can't be achieved with dual zone therapy, maybe that's an indication also for socket shield. So these are some of the things that we thought about, but it's something that, you know, there's an indication for everything. Even the inverted implant can't be used for everything. So, you know, there are indications for everything, but it was originally designed for extraction sockets, predominantly on the upper premolar anteriorly and the lower premolar to canine. So this is just my email, and like you said, this is my Instagram. So I'm just starting to become a novice with that. So let's go over to you now.
Steve, thanks so much for that. That's absolutely brilliant. I think it gives us a very good indication of what, how, where, when, and how things came about. And I must say, it's been a privilege to be part of the team with everybody. And I thank Graham for coming and asking, and for allowing me to give a little bit of a very minute amount of input into the development. And it's a pleasure to see where things have gone. While you were talking, I mean, Steve, your cases are just impeccable, and I tell anyone to go and look at your cases on Instagram, because they really are spectacular in every way. So what I did was while you were talking, the one interesting thing is I went and I added. Okay, so I'm just going to quickly go into my part here and just start sharing. You know, obviously, as you said, we are part of a wider group doing prospective studies, and our 1-year prospective data is ready for us to start looking, and we've collected the data. Now we're kind of ready to go. We've got 17 cases. We have 100% success. We are obviously doing the difference between ours and yours is a dual zone with the inverter. Ours is the inverter with socket shield. And obviously all the factors that work for dual zone also work for socket shield, because in essence, what we're doing you are creating 2 millimeters of bone around the buccal. We are maintaining what bone is there with the shield. So essentially we're kind of doing the same thing, just maybe in a different method. The great thing from our data is that we've got 100% shield success. And the other thing is what we learned from the 128 cases that we published, which we were lucky enough to have you review at the time, is we've reduced that 20% complication rate. And remember, complications are not failures. And I want to reiterate that, because a lot of people read into that paper and say, look at the 20% complications. Who wants 20% complications? Where in essence, only 6% were complications that really had a problem for us. And 12% of those complications were manageable and were treated. And all of those implants were absolutely fine. But what we've managed to do in this prospective study, and with the changes in the technique, and I'm not going to go into the technique too much tonight, but by doing that and by keeping things, by changing the way we looked at the changes in that study, we've reduced it to literally 1 out of 17 cases where we had an internal shield. So we've managed to maintain it. We certainly, the learning curve with the inverter was quite high for us, but obviously, you know, being front runners, one always has to, you know, as pioneers, one has to, you have to kind of try and find the path. You know, you are the path finder. So finding the path was not that easy, but I must say, with a lot of help from Costa, I must say thank you to him. He really helped me a lot. And with using the Versa drills, the osteodensification drills, it's really become a much better thing. And obviously with under preparation, we are now getting very, very high and consistent primary stability with the implant. As you say, it's not for everything. It's not something that one uses in every case, but it's certainly a great piece of armamentarium that we have in our goal. And I really look forward to publishing this, because this is also going to be it's going to be two things. It's going to be, number one, about inverter. Number two, it's going to be about socket shield, which obviously for me is the key factor, because we're hoping it'll be the first prospective study in socket shield, which will start to show both a reduction in complication rate, number one, and number two, a reduction a stability, a volumetric stability, which we will then follow over the next 10 years and publish 1 year, 3 year, 5 year, and 10 year, and hopefully see what we get insofar as all of those. So I think that's really exciting data, and I really can't wait to get that done with Jonathan and with Maurice and get it sorted out in that regard. But I quickly put this case in for you, which I actually finished on Friday or Thursday, I can't remember. But this was one that we added where we actually did the coaxis, and the reason we had to do coaxis for this case, we couldn't use a straight, because I generally use the straight for all the socket shields, because the socket shield really tends to push you well into the palate, and once you're well into the palate, you don't really need the coaxis. But the problem is in a type 1 socket, as we described in our publication, the radial plane publication, the type 1 socket, you cannot go into the palate. You have to go very straight. And the minute you go straight, the screw hole's always coming out of the incisal edge. You can never get it. You cannot go palatal, because if you go palatal, you go through the palatal wall into the palate. So from an anatomical point of view, we really had no choice. We had to kind of come in and we retrofitted the patient's own crown. And that's kind of how they walked. This is how they walked out in that. So I thought I'd just quickly add that into the presentation, that I don't do the coaxis often, but certainly it is something that we utilized for this specific case because of the class 1 nature of the anatomy in that. So here's a case that was referred. This is part of the study, and Henk is I can see in the crowd, he's part of the audience, and I just want to say thanks to Henk. He really sent us a lot of cases for this, and he still sends us cases for the study. And here we had a patient that had basically had this fractured ferrulous root, and we had a number of options. We had crown lengthening as an option. We had orthodontic extrusion as an option. We had forced eruption as an option, which is a little bit different to orthodontic extrusion. And we went through all of these things. She's a lady in her late 60s, and orthodontics was not really for her. She didn't really want to go into any formal orthodontic treatment. We looked at the different options, and we decided that she was actually sent for the socket shield, so she was kind of quite primed, but obviously we did our due diligence and made sure she understood all the possibilities before we jumped into just throwing her into the study. So those were the possible options that we had. When we look at the x-ray, it's a fascinating x-ray, because now you can see where orthodontic extrusion might not have been or even forced eruption certainly would have given us one hell of a headache. And you can see what we're dealing with. And here you can see, Steve, the classic scenario, a very, very thin buccal plate, a very, very angulated root, not much palatal bone there to achieve primary stability. So really a problem for us. So CBCT analysis is absolutely key for all of the cases that we do, because number one, it allows us, when we retract the gingiva, it allows us to see where the gingival margin is. And once we see where the gingival margin is, we can really utilize that as part of our measurement protocol, because we need to know how far we want to measure the distance between bone and soft tissue, so we know where our vertical positioning of our implant is going to be from a surgical point of view. We also want to know what our length of our root is going to be in relation to the gingival margin, so that when we start to separate the buccal portion from the palatal portion, we have something that allows us to get that. And I think that's very, very, very important. And once we've got that, we can really start off with the whole concept of socket shield. And what we start off with, the first thing we do is we start off with the Gates-Glidden-Burr, and that's really an important part of it, because what it allows us to do is it allows a non-end cutting drill to get access to the apex. And that's one of the key problems that most people have, is when they either use a drill or when they use a fast handpiece with a root resection drill, the whole concept is, how do you guide it? Now, some people are using guided surgery, and that's perfect, but the problem also comes down to the cost of drills that you're using, and how expensive are those guided drills for you to be using down a tooth, because it's going to blunt very quickly. We are working now with Versa to develop special Versa drills that will get to that quite quickly, and we've come up with some good ideas which will be coming out soon. And Chuck Schwimmer as well has also been instrumental, and Richard Martin, three of us together working to get that. So it's really been a great thing to do that. So once we've actually got the access, we go down with our drills again, constantly taking x-rays to make sure that we understand what our angulation is and making sure that we achieve that angulation. And therefore, by doing that, we never really go off-piste. We are always going directly down the canal because, number one, we've opened up the canals with Gates Glidden. Number two, we can get our drills straight down to the apex or as close to the apex as possible without perforating the buckle. So that's very, very nice way to be able to work it. We segment the palatal portion of the root. We remove the root out. We prepare the osteotomy. We take, if you look at the last slide on the right, this is one of the key x-rays that we take, because here we have taken the x-ray to confirm that there's no apical bone, that there's no apical tooth left. We have confirmed that we've removed the apex. We've confirmed that we've removed all the gutta perca from the area. So it's very, very important to make sure, taking that x-ray once you've cleaned it out, to ensure that you've got everything. And I'm not going to go through the details, but we have got a new publication on the step-by-step, which should come out in the International Journal of Aesthetic Dentistry. Myself and Jonathan and Maurice have, it's just been accepted for publication, not accepted, it's actually, it was supposed to come out in February, but obviously the delay in COVID has meant it's a bit delayed. So from that point of view, will come out later. So here you can see what we've now done is we've prepared the shield, and you can see how nicely we've got it down, utilizing the kit that the kit that we made with Megagen, and eliminating and removing. And you can see the key factor is when you take that part out, obviously that little piece that was tilted distally has cracked and come off, but you can see how nicely it came out and how we actually got the root split dead down the center. And I think by using the Gates Glidden, by opening up the canal, it really takes away the biggest difficulty. The highest degree of difficulty is going straight down the root. And for those of us who don't use guided surgery or dynamic navigation or things like that, which I'm luckily enough to use, but if you don't use that, which the majority don't, this technique using just the Gates Glidden is a really cool way to find your path down the canal without having to wander off and end up perforating either the palatal bone or the buccal bone. So these were the narrow diameter inverters, which we asked for because we wanted to use them in laterals and obviously lowers as well. So these are 3.53 millimeters. So these were a great addition to the group. And that allowed us to place. And I think the key fact is, if you look at this, I think, Dennis, you would agree, you could happily dual zone therapy the hell out of this tooth, because we've got 2 millimeters plus in this area, plus the socket shield. So you guys probably would have done the dual zone. We went for the obviously socket shield. It's our method of choice from our research group, from the PET research group, rather than dual zone. But I think the great thing is, from what you can see here, is how much jump gap you've got, how much space you've got for bone to grow around there. And I think that's the key factor in all of these. One of the key issues here with the smaller ones here, this is one of the times we were struggling to get primary stability because of our drilling technique was wrong. And obviously now we've improved it and we get primary stability on most of our cases. And because I didn't get primary stability, and because there was a cantilever, a provisional bridge, we didn't really need to put a provisional crown on. But every socket shield case that we do, we always do a custom abutment. We never ever not create an individualized abutment, for the reason that what we don't want to do is we want to make sure that we don't get an exposure of the internal shield. So by creating a individualized or custom abutment, what we do is we are then able to mimic that shape and make sure that when we put the final crown in, there is absolutely zero pressure on the soft tissue, which means you're going to get zero risk of exposure of the shield by putting in your final crown. However, and I think for me, one of the most important things, I'm going to show you the one case that had a complication, because I think that's the most important case to show out of all the successes. And what did I learn? And if I go back and I look at my photos, I can see here, if you look at this portion over here, if I can actually I'm just going to see if I can draw on here for you. I'm going to just play here and draw on here for you. If you look at this portion over here, you can see how flush with the gum my abutment is. But if you look at this portion here, you can see how thick that portion of my abutment is. And this was my mistake, because what I should have done here is I should have done that. I should have created that space, because what I did was not thinking, not checking, not making sure. As a result of my incorrect technique in this case, we ended up with an exposure. So if you have a look here, this is that integration assessment, which was always at 6 months. I think firstly, have a look at how beautiful the maintenance of the tissue is, okay? But the key factor is that because I put too much pressure, we ended up with that exposure on the outside. So the great thing about this is that it gives us the opportunity to show you how we dealt with it, because I think that's one of the key factors, because this is the biggest complication that we deal with is exposed shields. And the way we managed it is we simply trimmed the shield back. We also trimmed the custom abutment back completely to create a more S-curve in the custom abutment. And then what we did, what I like to do is I like to take a piece of connective tissue. Now, a lot of my group think it's not necessary. I find that if I use a piece of connective tissue, my predictability is higher. And I think that's always the key. So what I did was I took a small piece of tissue from the tuberosity. I de-epithelialized the piece of tissue, as one can see. I sutured that piece just to cover the area, and I put my healing abutment back in. And we left that for a further month. And when the patient came back 1 month later, you can see now that what we have beautiful soft tissue healing. You can see that the shield has been covered. There's no inflammatory response. And this is really what we're looking for. And again, if you look at the maintenance of the ridge at 6 months, is just absolutely incredible. So you can see individualized impressions being taken. This one we probably could have done with a coaxis as well. In this one also type 1 socket. And we decided to go for a cement retain, which we made a customized, individualized zirconium abutment, again, so that the cementation margins are no more than a ½ millimeter below the gum. And then placing the final crowns, you can see on day of cementation, a little bit angry, but you can see there 1 year post-op. Now, I think the key factor here is that 1 year is that we're looking at a thin gingival morphotype as well, with a very, very thin buccal bone type. And in my experience, it's not something that I would be able to achieve too often, to get that type of emergence and that kind of stability using the other technique. And that's why the socket shield for us is, and certainly for our group, is an important part here. So to end off, and we'll take some questions now. Here you can see the CBCT with the periapical CBCT showing good bone growth in the area of the shield, between the shield. And I want to say, just to finish off with these final X-rays, and thank you very, very much from us, from both Stephen and myself. And Stephen, we can have a discussion. And if anyone wants to ask any questions, please don't be shy. Let's put some questions in the chat box. And if you want to contact Stephen, there's his email address, schudmd@gmail.com, or you can email me at docg@mweb.co.za, or contact us at the Academy. or contact Southern Implants. They'll be happy to share everything with us. So with that, I say thank you very much to everyone who's joined us tonight. We are happy to take questions with you guys. And I wanted to see there. I wanted to see if Dennis, if you're available, if you were to join us, we would be happy to have you on board. If you're still around, if not, we understand. From there, okay. What I'm going to do here, there we go.
There's Dennis.
Hi, Dennis.
Hey, Dennis. Dennis, how you doing?
Let's just unmute Dennis.
Great.
Dennis, we need to unmute your audio. Just click on the bottom left-hand part of your screen. There's that little red icon there. Okay, we'll get Dennis back in a second. That's really cool.
Can you see me now?
Yeah.
Yes, thank you. Thank you. Good evening, Dennis. Welcome. It is an absolute pleasure to have you with us.
My pleasure. You guys did a great job. And listen, I owe you each a few dollars because you each mentioned my name at least twice, you know?
It's great, Dennis. I don't have to answer any of the questions. It's perfect.
No. I'm in the middle of a round of golf here. You have to let me go. You guys are great. We're a great team. We're great thinking. And there's obviously, you know, there's a place for everything. And that's really what it comes down to. And the key is based on experience and knowledge and biology. Each case is slightly different. To use one procedure for every situation is not indicated, but not for either one, whether it be dual zone, delayed, socket shield, it doesn't matter. Everyone has its ideal way. It's just like a class 2 restoration on a lower molar. There's 14 or 15 ways to restore that tooth. And any one of them might be best, depend on the situation, whether it be aesthetics, finance, and so on. And the same things here. And this, depending on what's left of the tooth, how much buccal plate is left, as you so well defined, I think that's really going to be the key to what you're going to wind up doing for the patient. And don't get hooked into any one procedure all the time, but be available, have it in your pocket, know when to take it out. I call it a banana. Every procedure is another banana. I say you got to be like the banana man, have a pocket filled with bananas, and then know what the greatest clinicians have the skills to do all of them and picks the right one at the right time. That's the whole story. So I thank you guys. I'll be glad to be part of any question. I was trying to be quiet. But
Howie, why don't you moderate and just, ask the questions? Why don't we do that?
Well,
Can you answer the questions, Howie?
I'm with some other people right now, but I'll be glad to. Why don't you guys just take it? I just wanted to thank you, and I have to sign off now. So you guys keep going, and I just happened to find out about this about 15 minutes before you started, so I figured I'd pop in and harass you guys.
Thanks, Dennis. Stay well. It's
Thanks,
great to
Dennis.
see you.
Nice to see you, Dennis.
Great
Nice
job.
to see you.
Thanks so much. Okay.
Okay,
Nice
so
to see you, Dennis.
Dennis, thanks for joining us. All right, so Steve is essentially. I'm just going to see if there were any earlier questions. Okay, so just from Sergio Rubenstein, there's just a great presentation. Invert is truly revolutionary as we always look at bone preservation. But if we were taking CBCT on clinical success cases with the old implants, many or most show very thin bone on the buccal zone. So I think that's really just a discussion. Steve, I mean, you mentioned that pretty much about the thickness and thinness and where you would choose it. What are your thoughts there?
Yeah, I mean, first of all, that's a great question by Sergio. He's a great prosthodontist in Chicago and a good friend. And, I don't do surgery, and I don't think surgery does as well. But as you pointed out, Howie, that, the consequences of not having the volume that you need, vital bone around the implant, eventually catches up later on. It's not in all the cases, but, in some of the cases, you start to see that. So Sergio, being a prosthodontist, has to contend with the aesthetic outcomes long term. So there's no question that conversation about biology and having vital bone was really from Kurt Pasquinelli, who's a periodontist in San Francisco, one of my classmates in Seattle. And I had met him in Chicago one time, not unlike when we had dinner together, Howie. And, I started telling him, I said, I got a couple of cases that, just don't look so good long term. Not a lot of them, but just a couple. And it gave me sort of pause. And he gave me a lecture on biology 101, and I bought him lunch, and it was worth every penny because he taught me so much about what the surgeons are looking for and how it affects the aesthetic outcomes. It's all about biology. And that's something that, Dennis has, lived his whole life by. So Inverta is really just about trying to, get the best of both in just the one design.
Cool, thank you.
So
okay, so the question, the next, there's two questions. Do you graft the jump gap in the socket shield technique? And then the next question is, what kind of bone graft do you use? Do you place in the jump gap? And I think for me, I was certainly in the old days a big dual zone therapy user before socket shield. And we placed a lot of xenograft. And I think you guys, Dennis, you use a lot of xenograft as well because of the lack of resorbability of it. Certainly from my side, I've moved more to allograft because I found that sometimes the xenograft it overstays its welcome rather than kind of converting to bone, where the allograft we will see long term, because I haven't used it long enough. But my preference these days would be allograft more than a xenograft. Do we need to graft the zone between a socket shield? And certainly our prospective studies show categorically for predictable bone formation between the shield and the implant, you definitely need a bone graft. 2 of the cases out of the 8, because we split up the group, half got bone, half didn't get bone, and 2 out of the 8 that didn't get bone, we actually see soft tissue. There's no bone formation. So I think from that point of view, it's really important. I know the root membrane guys are saying we don't need bone at all, just the clot is enough. But I think at this point there's not enough evidence to show one way or the other. So hopefully we will produce that evidence in our study. Okay. How long or far do you leave a piece of root apically? The question for that is we leave it 2/3 the thing. I think it's a very interesting, if you look at Herzler published a new publication on a complication 6 years later. And we've always advocated, our pet group, that the shield should be as long as possible and at least 2/3. And we published it in, I think, 2 separate publications it was published. And if you look at the complication that Herzler had and Otto Zur published, I think it's 2020, IJPRD in 2020, you notice that their shield was about 4 millimeters long. It's way too short. And it's one of the things that I certainly found, the shorter the shield, the less chance you've got of ankylosis of that shield, and that shield tends to erupt. So you need to have it as, we recommend 2/3 of the root. And that's pretty much ideal. Okay, just some very nice comments. Zeno, we spoke about Zeno.
There's a question from Andrew Ackerman, who's the inventor of the Max implant. Yeah, Andrew, which is great. Yes. Yes. Yeah. His question, Andrew said, when placing Inverta, do you find that the wider mid-body diameter tends to kick the implant to the labial? Do you find you have to compensate for this in your site preparation? So maybe you could talk about site preparation, Howie. But in the regard, I mean, what we're basically doing is we haven't made the implant wider at the bottom. It gives sort of that illusion because we've shrunken the top, so the bottom, may look wider. So it's the actual dimension of the X-hex coaxis implant that we're using, not the reduced platform one, but the regular X-hex coaxis. And so that apical shape and diameter, except for more aggressive threads, is really the same implant. It's the X-hex implant with the same basic thread pitch of about 0.5 millimeter. And so we don't really find that that's a factor. So it would be the same as using a coaxial. Now, if you determine that by using a regular coaxial, a tapered design would flirt with that apical part of the socket, then you may have to choose, maybe the 4-5 instead of the 5. Howie's version is a 3-7-5. Now you even make a 3-5 bottom. So it really depends. But we have found that in the maxillary anterior region, the bone is usually type 3 bone, softer bone. So the data, at least in our practice before the lockdown, we almost placed, we had about 96 inverted implants placed. And we looked at how often we undersized the osteotomy, and we undersized the osteotomy 60% of the time. And that's how we could then, get better, primary stability, even with the smaller diameter implant. And what we found is that initially, like I said, Dennis really likes using 5mm implants in diameter. And I thought for sure that we'd be using more 5mm diameter with the 4mm top. And what we found is that we're actually finding that we're using the 4-5, 3-5 combination more often, about probably 65% of the time. And the reason for that is that Dennis would rather use the smaller diameter implant combination. In case he can't get the stability he wants, he can always go to the 5. So we're sort of doing it in that way, and I think Valentina also. So I don't know if that answers the question, but it does have different, diameter combinations. So, and we find with the coaxial, we're able to really, engage more of that apical palatal bone. So we're finding we're having, very good results of it, the best of both worlds. So I know it is a little bit of a paradigm shift, Andrew, because of the original coaxial, and a lot of people are using the original coaxial down in South Africa. But when it was developed by Dale in 2002, it was really designed for healed ridges, not extraction sockets, because we know that, immediate implant therapy, Peter Worley 98 and Joe Kahn in 2003. So that's sort of the evolution behind it. Do you want to add to that, Howie, a little bit?
I think you've pretty much nailed it. Certainly, I think with the drilling protocols that have been developed now by Costa and Plasman and things like that, I think it certainly made a huge difference. I struggled in the beginning with the protocols because there was no set protocols. It's the same as I struggled with socket shield in the beginning because there were no set protocols. You kind of have to bump your head until you actually develop the protocols. But now I think Graham and them have now got the drills right. Certainly the use of the Versa drills also, Costa would agree, makes a huge difference to the ability to prepare properly. And I'm happy to say that they came to with the strong thread design because I was very anxious about not having a strong thread design. And I think that strong thread design does tend to, Andrew, I think we found that does tend to cut through the palatal bone a lot easier than having blunt threads, which was the initial design, and which I think was a problem for that. So that the stronger the thread design, the more it'll cut through that bone rather than push you buccally.
Yeah, I got to give you a lot of credit for that because I know you had conversations with Graham about that personally, saying that the original thread design wasn't deep enough. The thread pitch or distance was ideal. Orsini showed that about 0.5 millimeter means that there's more threads contacting bone, but the depth of the thread was too shallow. So by changing that, really made a great improvement to really give us what we need, especially with the smaller diameter combinations. There's probably 2 other questions. There's one from Charles Schwimmer and another one from Sacco that probably you could answer, Howie. One by Sacco says that, no, I'm serious. One by Sacco says that Ossix Volumex membrane, which that's Greek to me, work instead of allograft in dual zone technique. So an Ossix Volumex membrane.
An Ossix is a type of membrane. It's Israeli product where the membrane actually becomes part of it actually grows and forms bone itself. I don't have any experience, Sacco, so I can't really give you any idea on that. So I apologize. Whether it would work in dual zone, I'm not sure. What would one achieve? Would one achieve bone? Possibly could, because essentially it has shown to become not, it doesn't just dissolve, it actually becomes incorporated in the bone. So your biological thinking might not be too far off there. But I can't give you an answer because I've never used it and I don't use it extensively. Chuck, how can we not answer yours? Chuck is part of our research team and we've published along with Chuck. So the question, what is the biological rationale for using xenograft as part of the dual zone? Chuck, if I can answer that, obviously from their point of view, the whole concept of that is about non-resorbability. Is there any human histology? I think, as far as I understand, only the one that Dennis and you published. Am I right, Stephen?
Well, in regards to, the reason why that Dennis and I started to use a lot of xenograft biowas collagen is that Jan Lindy and Linder had published an animal study asking the question is that, well, if the xenograft gets caught in the soft tissue zone, is it an irritant or not? Now, don't forget, that's a dog of one and an N of one that they sectioned, and that's showing the best histology. And what they alluded to in the paper was saying that, at least from a histologic standpoint, if the particles got into the soft tissue, it didn't seem to be an irritant. We then did about 50 cases, and we found out that about 5 out of the 50 had that irritation. And that's about a 10% rate of complication. So we found that, maybe a xenograft, especially in thin tissue phenotypes, it can become an irritant. If it's a thick phenotype, we just found that when we disconnect the provisional, that the particles just sort of sit in the soft tissue sulcus. The tissue's so thick that it doesn't seem to penetrate through it. But we found that in the thin phenotypes, it was definitely a problem. From a bone standpoint, in the bone zone, what's very interesting, and I learned this from Dennis, is that no matter how hard you push on the graft material and what graft material you use, if you look at any histologic section, and what you'll see is that what's contacting the surface of the implant is always new bone from the patient's blood clot and the wound healing potential, and you never see particles actually touching the surface of the implant. So what that actually means is that during the wound healing process is that the particle gets pushed away from the implant surface, and the particles only act as a filler for aesthetics. And we learned that obviously from Maurice and David Garber, that you need to graft for aesthetics. So what is the particles doing? It's acting as a filler to maintain ridge shape. And in the soft tissue, it can also thicken it, provided that you use the correct. So yes, allograft in the soft tissue zone. And it's an interesting discussion because why would we advocate dual zone when my partner, Dennis, like you, Howie, is a periodontist, and periodontists love doing connective tissue grafts. So it's an interesting statement because if a periodontist is saying, well, I'd rather do dual zone, I don't have to do as many connective tissue grafts, I think it's saying something. And I asked Dennis, why? He goes, it's just faster and easier, Steve, to do dual zone. We're going to get the same outcomes as what Joe Kahn showed. They both gain about 1 millimeter in soft tissue thickness. So it's just easier and more efficient. And knowing Dennis, he likes to keep things, simple. Why not use a dentin graft? Does that meaning, Howie, that you're going to take the tooth and you're going to grind it down?
I must say,
Could you comment on that?
It's a fascinating thing. I've been resistant, and obviously, Yitzhak Binderman from Israel was the developer of dentine graft, and I was very. It takes a little bit longer, because you have to take out, prepare the tooth, grind it, etc., etc. And if you're using sticky bone PRF to mix with it, you have to do it at a different time. But I have to say, there's one thing, Shnezana Pol, who is part of our research group, and is one of those people that is just as honest as the day as the sun's in the sky, and and she shows just the most amazing histology that she's just published, and it blew me away, the kind of results she was getting using dentine graft, which she was not getting with xenograft, definitely not, and she wasn't getting with other types of materials. So dentine graft certainly is something that will, I think it'll, once the histology starts to come out, and she's got human histology as well, quite a few human histologies showing really amazing, even cementum formation around the root. It's just incredible what is being developed from the graft. So I think, Chuck, will it come? Yes, it'll come. I think as we develop more data, as the techniques get better and easier, and people become more au fait. Again, it's one of those slow things that's going to slowly turn. We're fighting against huge conglomerates that have invested interest in what they're doing. So it's very difficult to talk about. Okay, so here from Richard Bryant.
Yeah, that question is a really good question.
Okay, I'm going to answer it. I have to say, Richard is a maxillofacial from South Africa, and somebody that I was at university with. Nice to have you with us, Rich. A great presentation by Stephen Howard. With COVID-19, would dual zone be preferable in terms of not generating large aerosols for protracted periods of time at this stage, and then use socket shield when COVID-19 is over at lower risk levels? I suppose that is it's a very good question. For me, I haven't had as good results with dual zone as Steve and Dennis have had. So from my point of view, I would still try and go to it, but I would certainly use it with as much reduced aerosol as possible and possibly delay. But if I have a case where I've got a beautiful thick buccal plate, would I rather go for one? I actually, funnily enough, did one today where I opted not for a socket shield because I had such a thick plate and to reduce the aerosol. So I have to say I did exactly that today, where I reduced it. But if again, there's no major evidence about dental aerosol and COVID-19 spread at this point in time. I think Marcus Trulsch did a lot of great research and great looking at it to see, and there's not really much that we can see from it. So as long as you're using the right amount of protection, as long as you're using your high volume evacuations and your PPEs, I don't think it should be too much of a problem for you. Steve, anything from your side on that?
Yeah, that's a great question. I mean, I think you had answered it perfectly. I know, we're very concerned about it, but like you said, we don't know how many dentists have become infected from it or staff as yet, but we certainly want to try to reduce it if we can. But, the crazy part is that, I still have to use a handpiece to adjust the patient's occlusion. So I'd still have to pick up, the handpiece to adjust their bite. So, and that's using an aerosol. So, how much, cutting the tooth or, adjusting a tooth to prep it for a crown, or adjusting the bite on the temporary. I don't know.
Yeah.
And
there's also new technology coming out as well that helps to reduce aerosols. I think Eichtow Wheels got a new shield that covers the face with the suction in the middle, which is pretty cool. So there's lots of fancy things which are inexpensive that are coming out to help. But I think as all great things, this too shall pass, and we shall get back to some semblance of normality. And yes. I think it's late, and we've answered a lot of questions. And Steve, it's time to say goodbye. Again, I want to say, sure, thank you so much. It's a pleasure and an honor always. It's great because you were one of my mentors, as much as you didn't know it. Reading all your publications as a young registrar in South Africa. So it's always a pleasure to have people like you as friends. The people that you looked up to as idols when you're growing up, and to have you here all the way back in South Africa, and to have everybody who came from around the world, Steve, it's a pleasure and an honor. And then secondly, to Southern Implants for the sponsorship for this, to make it available to more people than just what Zoom allows us to. So thanks to Southern Implants and for sharing that with us, and for allowing us to come on board, and to everybody who stayed here for almost an hour and 45 minutes. Thank you so much. So good night to you all. Steve?
Thank you, Howie. Appreciate it. You're a phenomenal surgeon. Thank you so much for teaching us all about how to do socket shield. I definitely think that your step-by-step approach is so important because it is technique sensitive, and you have to have, you know, good education to make it so that it's more consistent. So thank you for all the things that you're doing to improve dentistry. So again, hope to see you soon, my friend.
Yeah, I look forward to coming back to New York. I miss it. I miss the traveling.
Yes.
For those of you, this will be available on our website. So it's not going live on Facebook, but if anyone's interested or you want to share it with anybody, it'll be available on the Implant and Aesthetic Academy website. So email us and we're happy to share. Otherwise, good night, adieu, and to everybody around the world, stay safe, stay COVID-free. And we look forward to getting back to some semblance of normality and meeting you all in person. Thanks very much. Good night.
Thank you. Good night.